Good afternoon, ladies and gentlemen. So we're just going to talk you guys through the evolution of Pgd technology. Is that right? So IVF and PGT technologies have been developing in tandem over the last 10, 20 years. And we're now kind of really entering a golden age where the IVF capabilities and the genetic testing capabilities are really in a good place. So from the IVF perspective, we've got improved culture media, improved incubation systems, improved cryo systems like vitrification that allow us to generate blastocysts, that allow us to do frozen embryo transfers. And from the genetics perspective, we now essentially have quite a lot of off-the-shelf genetic tests that really slow down and speed up the patient's time to treatment. We've got comprehensive chromosome screening. We're no longer limiting what we're testing for. And we can detect mosaicism, that grey area between the yes or no. And so this leads us into a position to offer PGT at the best point from an embryology perspective with excellent tests from the genetics perspective as well. And just to mention to everybody, we've now got a new nomenclature, PGT, pre-implantation genetic testing. And it's been split into PGT-A, which is pre-implantation genetic testing for aneuploidy, what we previously referred to as PGS, PGT-SR, which is pre-implantation genetic testing for structural rearrangements, what was previously PGD, and PGT-M, pre-implantation genetic testing for monogenic diseases, again came under the umbrella of PGD. So I'm mainly going to concentrate on PGT-A and PGT-SR, what we know of as chromosome analysis, because it's the area that has really evolved the most in the last 10 to 20 years. So when we started doing chromosome analysis as a way of choosing embryos, it came from a very logical place that we had euploid embryos, which had the correct number of chromosomes and would have a higher likelihood of a successful pregnancy, and that we would have aneuploid embryos, which had the incorrect number of chromosomes and would result in failed implantation, miscarriage, or genetic disease. And it seemed a pretty logical test to try and apply. The first cases were performed in 1993 using a technology called FISH, Fluorescent in Situ Hybridization. And as you can see, it was based on counting up these coloured dots or probes that hybridize to the chromosomes. Obviously, we've got 22 pairs of chromosomes, 1 to 22, and then the sex chromosomes X and Y. And so a limitation of FISH was that we could only test a limited number of chromosomes. And in 2007, so when we'd already been performing this technology for 14 years, the Mastenbrook paper came out, which was really a paradigm shift in the field, saying, wait a minute, not only does this at best not work, but at worst, it might actually be decreasing some patients' chances of successful pregnancy. And that's one of the main reasons for the talk today, to talk people through the evolution of PGT, because we still come across so many people in practice who say, PGT doesn't work, I've read the papers. And it's really just to highlight how what we do today in what some people are now calling PGT-AS 2.0 is completely different to what we were doing over 10 years ago now. And if you think about it, it's the same in the embryology lab. The culture media we use is different, the incubators we use are different, and it's the same in PGT. We're doing something completely different. And it's not to say previous science is bad, but we always use the best that we have available to us at that time. We wouldn't say we had bad embryologists 15 years ago, but it was super exciting to see a blastocyst. So science changes. Now, this is just basically displaying why it's really important to look at all 24 chromosomes, which was one of the main issues with FISH. Obviously, when we were selecting what chromosomes to test for from a limited panel, you think, okay, what are the chromosomes that are involved in miscarriage or the birth of a child with a chromosomal syndrome? What is the highest risk to our patients? And if we look here, we can see, for instance, chromosome 22, monosomy and trisomy, chromosome 16, monosomy and trisomy. The embryos, the chromosomes that we were testing do actually make up a large percentage of the abnormalities that we do see in embryos. But you can also see that every single chromosome is represented there in either a trisomic or a monosomic form. So if you're only testing for 7 chromosomes or 9 chromosomes, you're going to be putting back a lot of so-called euploid embryos that do still have a problem. Alongside the move to comprehensive chromosome screening, we also saw a lot of movement in terms of the embryology lab and what we were doing for biopsy. In terms of the issue with the number of chromosomes, people also did worry about doing the biopsy at day 3 and how reflective one single cell could be of the entire embryo. Because of that, quite a lot of people did move to polar body biopsy. Because that, although we were missing out on information on paternal contribution and we were missing out on information on mitotic errors, we were getting close to 100% of maternal errors. And my personal practice was, at that point, before the Mastenbrook paper had come out, we had already started experimenting with polar body biopsy and comprehensive chromosome screening. And again, it's one of those situations that people say, well, why did you do polar body? Why didn't you do trophectoderm? Because we weren't very good at making blastocysts 10 years ago. Again, we would get blastocysts, but we had a lot of embryos that wouldn't develop to that stage. So once people improved their culture systems, we got better incubators, we got better culture systems, we were then able to move to biopsy at the blastocyst stage. And I can sort of chart out my own lab practice as going from day 3 biopsy to polar body biopsy to day 3 biopsy again, then on to blastocyst biopsy. So part of being a scientist is always changing what you're doing based on the scientific evidence that's available to you at the time. So it was a method known as CGH, or Comparative Genomic Hybridization, that allowed us to move to comprehensive chromosome screening. The first technology was called Metaphase Cgh, which basically was hybridizing your test material against a normal metaphase. Good idea, but technically difficult and very laborious. And so Bluenome came up with the 24-Sure array slide, which allowed us to do this testing in the chip setting. And everybody's very, very familiar with this diagram showing your embryo DNA and your reference DNA competitively hybridizing to then tell us if there was a gain or a loss of chromosomal material. And I always like to show these images here, because if I showed them to the genetics lab today and said, what would you call those? They would say, that's a no result, that's a fail. These are the images from the first clinical case. And we transferred an embryo resulting from this, and the patient got pregnant after 14 cycles of IVF. So again, much like the technologies, much like the blastocysts, that looked amazing. In 2007, that looked amazing. In 2018, the lab would call it a fail. And we'll look at what the images look like today. So this is what the lab is used to seeing today, next generation sequencing. And arrays do look a lot better than that today as well. So next generation sequencing, we started using it around 2014. And it was initially used for patients with chromosome rearrangements, particularly ones with small imbalances, because there's a better, we can get smaller imbalances from next generation sequencing than we could with the arrays, because it is a sequencing-based technology. But a byproduct of starting to use next generation sequencing was that we could then start to see mosaicism. Because we're testing more than one cell, we'll see that some cells may be normal, some cells may be abnormal. And that's when you get this picture here, that rather than it hitting the green line or the red line, it's somewhere in between. And that indicates to us that within that sample that's been tested, there's some euploid cells and some aneuploid cells. And to begin with, people didn't really know what to do with that information. For years, people had been shouting at us saying, we don't want to test a single cell because of mosaicism, test multiple cells. So we tested multiple cells, and then we got to the point where we had a technology that could differentiate and say this is euploid, this is aneuploid, this is mosaic. And then everybody shouted at it and said, don't tell us it's mosaic, what are we meant to tell the patients? Is it good or is it bad? Should we use it, should we not use it? And I think we're in one of those situations where we just have to be honest with our patients and say, you know, euploid embryos have the best chance of implantation. Aneuploid embryos we're not going to use. Mosaic embryos, we don't always know the answer. They can create clinical pregnancies. They do have a higher rate of miscarriage, but there are healthy babies that are born. And the people who have been in a situation where they've been able to transfer these embryos have now been able to distill that even further to say embryos that have a level of mosaicism of between 20 and 40%, actually their chances of success are pretty much as good as embryos that are euploid, and embryos that have mosaicism at a rate of 40 to 80%, you probably don't want to use. The professional guidance that is out there at the minute stratifies the risk based on the chromosome rather than the level of mosaicism. And that is still something that a lot of people probably do want to use in clinical practice. Because I think we would be very brave if any of us wanted to transfer an embryo that was mosaic for, you know, trisomy 21 or trisomy 13. So we're always going to have in our clinical practice embryos that we're not going to want to transfer. So we do know that we are now in this situation where we have some embryos which are mosaic in all parts, and some embryos in which the mosaicism may be isolated to the trophectoderm, or even riskier for us, where the mosaicism is isolated to the inner cell mass. And this is where we have our limit at this point in time. We can tell you if a sample is euploid, we can tell you if it's aneuploid, we can tell you if it's mosaic. We can tell you that low-level mosaicism correlates well with good outcomes. We can tell you that high-level mosaicism correlates poorly with outcome, but we cannot give you 100% of an answer as to whether that is representative of the inner cell mass or not. But again, it comes to how important is that, because you need a functional placenta for a successful pregnancy as well. But as I say, it does seem that low-level mosaicism, regardless of the chromosome, correlates positively with clinical pregnancy and successful outcome. So we're now in the situation where we have had a number of RCTs, we have had a number of observational studies, and we also have had data that has come from professional regulatory bodies as well, that all seem to correlate and agree with each other. Whereas when we started doing this 20 odd years ago, some people had good results, some people had bad results. But at the minute, all of the data coming from very different sources, RCTs, observational professional bodies, all seems to be agreeing with each other. And what we're seeing is an increase in implantation rate per embryo transferred. So this is the very sort of common diagram that we see of implantation decreasing with age in blue, where it is standard IVF, And then in red, we can see patients who've had PGT-A, we've got a normalization of the implantation rate across the ages. And this is data that comes from SART, the Society of the American Reproductive Technologies. And it's also reflected by the data that we've collected from our legacy genesis and reprogenetics labs as well. Again, the inverse of this is that in blue, we see with female age that we get an increase in miscarriage with maternal age. In red, with patients having PGT-A, we see a normalization of the miscarriage rate across the ages. And a side effect of this has been an increased use of single embryo transfer. So again, you see here in blue, this is the average number of embryos which is transferred in a standard cycle in US clinics, versus in red, the number of average embryos that's transferred in PGT-A cycles in American clinics. So the data that's coming out of PGT-A is giving clinicians and patients more confidence in single embryo transfer. Because we do have to remember, when patients come to us, we're not just wanting to get them pregnant, we want to get them pregnant through a whole 9 months of gestation with a healthy baby at the end of it. And I personally have always disliked putting back multiple embryos after PGT-A because you're removing one risk factor but introducing another. And it does seem to be a very nice side effect of PGT-A that people are becoming more confident to say yes to a single embryo transfer. And as I've said, the RCTs, the observational studies, the meta-analyses, and the official data do all now seem to be in agreement of this when we are looking at data from day 5 embryo transfers using a comprehensive chromosome screening platform and doing a frozen embryo transfer. Thank you.